trying to understand exactly who we should take to transplant for MDS. I think that there's a number of factors that need to be considered. These are patient-related factors such as age, comorbidity, and then the transplant disease indications themselves. So if we think about the transplant and disease indications, clearly MDS is a spectrum of diseases in many ways with differential prognoses, and the likelihood of transforming to acute myeloid leukemia, the overall survival, are all those factors are all related to a number of biological characteristics, including obviously the age of the patient, but also bone marrow blasts, genomics in terms of cytogenetics, and increasingly we're now integrating the molecular profiles of patients and understanding which gene mutations may confer additional risk to patients, and suggest that those patients who might be what we classify as perhaps even lower risk MDS may actually be upstaged to a higher category of MDS risk, and therefore potentially helping to select out those patients with lower risk MDS who might benefit from transplant. As a standard and as according to the ELN 2017 guidelines, generally the indications for transplant in MDS are for those lower to intermediate risk patients who are transfusion dependent, or perhaps who have severe cytopenias such as platelets below 30, or significant neutropenia resulting in recurrent infection. These sorts of patients would generally be considered suitable for transplant based on their disease characteristics alone. And then as you consider the higher risk MDS patients, who generally will have an excess of blasts, but will also likely have adverse cytogenetic or genomic profiles, these patients we would tend to say will only be cured long term if they proceed to an allogeneic stem cell transplant. But we need to consider, alongside the disease itself, age per se is not a barrier to transplantation, and increasingly we can see that given that the nature of this disease means that the median age of diagnosis is around 71 years of age, we need to be able to offer transplantation if we want to be able to cure some of these particularly higher risk patients with MDS by offering them stem cell transplant. So I think increasingly there's an understanding that age itself is not a barrier. And actually, when you consider age, it's more than the figure itself. You need to consider performance status, and there's clear data surrounding the impact of performance status on the ability to tolerate a transplant in older patients. And then other comorbidities. And actually, I think something that I hope we'll see more of as we go forwards is people performing more objective, comprehensive geriatric assessments. And I think to be able to do that, we'll probably need to define a clear tool that is potentially easy to use and perhaps doesn't need additional resource. But ideally, the gold standard would be to perform these comprehensive geriatric assessments, which we have time to do in the MDS setting, to try and define best those patients who we think will be best able to tolerate a stem cell transplant. So I think, in answer to your question, we need to consider a number of factors, taking in the patient, the disease, but also the type of donor that's available to them. And I think increasingly, obviously, we would only expect a certain proportion of people to have a sibling or matched unrelated donor, and there'll still be a significant, at least 30% of patients who may not have a clear donor across the board. And so that's where the rise of transplants such as haploidentical transplantation is being seen across the globe, and is showing similar outcomes to matched unrelated donor transplantation. So I think the other consideration is timing. And this is a difficult question and continues to be a difficult question in MDS, because for many patients the disease can be indolent and then progress at a later stage. And being able to define the exact window, particularly in patients who may have a good blood count but have adverse molecular risk profile, this is still an area that I think is somewhat uncharted in terms of we don't have good prospective data, given the nature of the type of study that would need to be carried out to be able to tell us exactly when to intervene in those patients. But I think as going forwards we incorporate the use of these molecular profiles and being able to understand the genomic data, I hope that from studies we will start at least to be able to put together a clearer understanding of when to intervene. But certainly in terms of retrospective data, there is some data that suggests that waiting till disease progression could be a better time to proceed. However, there's also conflicting data in that other models have suggested that intervening earlier before the actual time of progression to advanced phase disease may result in better outcomes. So I think there are still a number of unanswered questions that hopefully will be addressed in the coming years.